There we go. Good morning, everybody in the room. There we go. And welcome to January's Health Overview Scrutiny Committee. Before the meeting starts, I just want to inform you that this meeting is being live streamed and recorded, and please note that all remote participants are muted at the offset of the meeting and are only able to speak at the invitation of the chair. Please raise your virtual hand if you wish to speak, and then only unmute when the chair invites you to make your contribution. As chair, I may ask that you are muted if you don't participate in this way. For reference, we have got Rachel Robinson, Director of Public Health, online via Teams, and we have got Councillor Mandy Duncan joining us via Teams also. I'm going to move on to item number 1 swiftly, and apologies for absence. And we've had apologies from Councillor Vicky Moore and Councillor Colin Stanford this morning. And like I said, Mandy is joining us remotely this morning. Then move on to item number 2, disclosable interests. I'll just check with all colleagues if anybody's got any disclosable interests this morning. No, brilliant, thank you very much. Okay, item number 3, minutes of the meetings held on the 20th of October 2025, which seems like a decade ago. Unless anybody has anything specific that they want to raise about those minutes, I will take them as read and move on. All colleagues happy with that? Yep, that's fine. So I'd like to propose that we accept those minutes. Do I have a seconder? Thanks, Chris. All those in favour? Yes, thank you. Okay, we're then going to move on to public question time, and we have got one public question that has been submitted in advance of the meeting from David Sandbach. David, can I just invite you to take a seat on my left hand side, please? Perfect, thank you. David, if you just want to introduce yourself, and then if you want to speak up the question, and then if I can invite Richard Gallio to respond, if that's okay. Thank you, David.
Thank you. My name is David Sandbach. I am an ordinary citizen of Shropshire, but I do serve on the Shropshire Council's as a co-opted member on the the
Joint HOSC.
Yes, joint HOSC. I've got 3 questions. The first one, will the recommendations in the report that has been submitted be subject to public consultation? Do you want to take them one at a time, or do you want to do the 3 first?
If you read out the 3,
okay,
and then
thank you. Will the report and recommendations in the report be subject to approval at a full meeting of the Shropshire, Telford and Wrekin ICB, or will the report and recommendations be approved by the Shropshire, Telford and Wrekin ICB Primary Care Commissioning Committee, which is a committee I suspect you don't realise there is? Then the third one is, how will the report and recommendations empower patients?
Rachel, so you've got a speaker in front of you. If you press on the right hand button, that will go red and they'll be able to hear you.
Sorry, can I just ask which reports, David?
I do beg your pardon, the report that's on the agenda today.
Thank you, Rachel.
Okay, thank you very much for the questions. And obviously we're going to be presenting it a bit more fully going into the meeting, but happy to take those questions at this point. So the first question around the report will be subject to public consultation. All of the parts of that, the local commission service review have a full impact assessment done on them. So in that impact assessment, so it's a fully integrated impact assessment, it looks at things like quality, impact on the public, etc. So all of that work has been done around the services that we're looking at. This will be this is part of public engagement that will form part of that, but there will not be a formal consultation in the way that you're describing, but it's the impact assessment engagement. We are working with general practice, we're working with secondary care, so there's a full engagement process that comes around that. in response to your second question around the governance, so there is a governance process that sits within the Integrated Care Board. So all of that governance process is directed towards the statutory board, the Integrated Care Board. As you know, it's moving towards the cluster board now, but it's an STW ICB board that's part of that. All of this will go through that governance. So we were talking about the primary care commissioning. It's a group that meets to look at those the proposals around primary care. It also goes around the commissioning working group, but all of that is directed towards the board. So there is a robust governance process that will sit behind this in terms of those local commission services. And the ultimate sign off is the ICB board. So but the commissioning working group, primary care group do that work behind and send recommendations to the board. So that's all in place and sits behind the local commissioning services. In terms of how will the report and recommendations empower patients, I will come on to some more of the detail, but this is really, I'm very passionate about the fact that this is about delivering equitable, fair services across the patch, removing the inequity that might exist about how they're delivered. So we will make sure that the standards are set, the outcomes are set around these services, so that patients, wherever they access it, are accessing the same quality, the same level of service and the same expectation as they go through that. So in terms of the patients of STW, that is the empowerment to feel that they know that those services are going to be at a level that removes that patchwork delivery. And I think this review is really about those principles, absolutely about standardising, making sure that we get the highest level of outcomes for patients wherever they access those services. And I think that's a really important principle around some of this.
Thank you, Rachel. David, you're entitled to a follow-up supplementary question.
Yeah. Where's the impact assessment? When would that be published?
So the impact assessment will sit around all of this papers that will go to the board. So those will be, I don't know if you're able to give me more precise time. I don't know if we're able to give precise timings on that, but we can certainly get back to you about the timings of that. But they will be absolutely transparent and visible. The exact timing of those, I will let you know if that's okay.
But you have the impact assessment now, don't you?
Yes, we do.
Well, why didn't you put it in with your papers?
I think
Sorry,
we've got the one question, David.
I'm happy to get back to you around the timing of that. Yeah. And you know, we would absolutely be transparent and open about those impact assessments and how they've been done.
Thank you. Yeah, follow-up information via email would be really useful. Yeah. Thank you. Thank you, David. Excellent. Okay. We move on to item number 5 and swiftly move away because we have had no member questions to this date that I'm aware of. No, fabulous. Okay, so we do move on to Rachel again, and we're going to look at the review of the local commission services and primary care. We've got an update from you. That's okay. I think there will be a PowerPoint.
Yeah, thank you very much. Just help us go through that.
There we go. Are you okay with that?
Lovely. I've got it come to me anyway. Thank you very much.
That's
can you still hear me through the microphone when I'm on my computer? That's fine. So by way of introduction, I think before I start, I'm Rachel Gallio. I'm Interim Chief Medical Officer for the Integrated Care Board for STW and working across the cluster with Staffs and Stoke as well. I'm just for context, I'm a GP by background, been a GP for 24 years and still practiced in the Uttoxeter area in Staffordshire. Taken over the role in STW. Apologies from Liz Walker today. She's the head of primary care who's not able to join this morning, but she's been involved with this review as well. So can I have the next slide, please? So We're talking today about the review of local commission services across Shropshire, Telford and Wrekin. I think it's really important that we put into context what that is in terms of general practice services. So we are doing a full comprehensive review of the locally commissioned services in general practice. The local commission services are delivered in addition to general practice, general medical services. So well, I'll come on to that in a bit about what general medical services are, so we're really clear what we're speaking about here. The local commission services vary across footprints, and we do have the ability to make them very locally relevant for the patient population. As I've already described, we're doing this review in primary care to make sure we've got fair, sustainable and aligned services that meet the population needs. So these are additional services that general practice provides, but we have the ability to shape those with our local GPs. So the LMCs, the local medical committee, have been involved in this, as have the GP board chairs, and really focusing on the needs of the patient as we do that. These local commission services have been delivered for many years, but the time really is about making sure that we get an equitable service, so we don't have any patchwork sort of delivery of these services, making sure we've got the highest of standards for patients. So it's a really good opportunity to make sure we look at those services and look at that revised model from April 2026 and continue to develop that as we go through the year. So if we go to the next slide, please. So just to be clear around what general medical services contract is. So this is a main contract that a general practice would have, and this is for the core general practice services. This is not what we're talking about, and it's really important that we understand what that GMS contract looks like. So this is around this is a national contract that's negotiated, so very different from what we're talking about from the local commission services. This is a national contract, and this is the standard contract around delivering diagnosis, management of illness, health advice, just the day-to-day of general practice. They can also have additional services such as vaccinations, cervical screening, contraception, health, child health surveillance, and then on top of that, we're talking about the local commission services, which are in addition to that standard national contract, and those are the ones that we can have more sort of autonomy locally about how they're delivered and what the services need. So it's very, very different. We're not talking about that standard national contract. We're talking about the ones that we can deliver locally. So if you go on to the next slide, please. So what are local commission services? Local commission services, they're called various things in various places, but every ICB will have the ability to contract those local commission services with primary care. So they may be called, in some areas, LESs, they're called LCSs here, and it's separate from that core GMS contract, and GPs receive extra funding for that, and it's designed, it provides that ability to address the real local needs and priorities in the area. So some of the things that we're looking at, we've put a few of those examples there, are things like phlebotomy, so where you access to having your blood taken, simple wound care, contraception, ring pessary fitting, spirometry. And some of these are the core ones that have already been delivered locally, and things like the enhanced health checks for the serious mental illness, so the SMI checks that you may have heard about as well. So these are additional services that are commissioned, they're contracted locally, and then they are designed and contracted to fit the local need. And as I said, these have been delivered locally for some time, but there is an opportunity for us to make sure we look at that population, look at the need, and make sure we design these services appropriately around the population need. I think it's a really good exercise for us to do periodically to make sure that the ability we have to contract is done to meet the needs of the population. So I probably have talked to the next slide a bit already, so could go. So why is the review needed? I've talked about that patchwork delivery. We have, as time progresses, created a bit of patchwork about how it's delivered, how different services are delivered depending on where you access it. And it's a real opportunity to even that out and make sure we get those outcomes that we're looking for and the highest level of outcomes that we can. Significant variation does exist, and we definitely want a more consistent approach towards the LCSs. So we need to make sure we've got equity of access, drive down that unwarranted variation, and make sure that we're absolutely those commissioned services are delivering national best practice. We need to work with our general practice colleagues around the financial sustainability and delivering them in the best way that we can with the resources that we have. And it's about the 10-year plan as well. And many of you will probably know around the 10-year plan that we're looking at shift from hospital to community. So this really does support it. And given that the 10-year plan has come out came out last year, it's an opportunity to make sure we deliver that care as much as we can closer to home and appropriate for the patients as well. So if we can go up to the next slide, please. I think some of this we've covered already, but it's around improving access to those services throughout the county. Very much around long-term conditions as well, making sure that the long-term conditions and health outcomes are addressed. Standardisation, we talked about the 10-year plan, and many of you will know that within that's about their neighbourhood health service development. This conversation isn't about neighbourhood health, but this is really relevant to how services delivered as part of the direction of travel around neighbourhood health, which is going to be really important around service delivery. It also gives us an opportunity around wider service delivery. So when we're talking about some of these services, they input into wider transformation programs, and absolutely making sure that we've got the front end that's delivered tying in with other transformation programs. As things progress, we need to make sure it's evidence-based, and we really make sure that we've looked at that evidence and we deliver that in a way that's going to get the highest outcomes for the patients. We've talked already about how these are subject to the integrated impact assessments. So the impact on patients, how this might change, the quality, all of that is pulled into those impact assessments, the equity and value for money as well. And throughout this, we absolutely need to engage with stakeholders as necessary, which we have done to this point, to make sure we develop it with service users and with the general practice colleagues along the way. So we've talked about the governance already. There is a dedicated subgroup that's leading this with general practice colleagues. We talked about the LMC. We need finance in their strategy and communication engagement colleagues as well. We are producing a case for change document, and it will give the scope and methodology around this work, and we absolutely commit to that transparency and open and meaningful stakeholder engagement around this. So these are services, some of them that are already being delivered, and that those the way they're delivered be looked at to make sure we be best practice. Others we will look at and work with general practice in terms of sort of new services and services we might feel that are we might develop it in a different way. So we are working across several of those services to make sure we improve them and make sure that delivery is consistent. So if we can go to the final slide, please. So the next steps, we continue that engagement phase with general practice to get those final proposals, making sure we've got those structured conversations with them and taking feedback and targeting these discussions. Obviously, there's several services here that we're looking at. So we are there's sort of those individual service lines that we will take through with our colleagues in general practice to look at those and make sure that they align with the rest of the pathway. And we're also working around those potential mitigations around around the integrated impact assessments, and we will be looking to start this process from April onwards, so April this year. Again, shaping it through the year as we go to make sure that we get that the highest possible service for the patients of STW. So thank you. That's a fairly quick run through of where we are, distinguishing them from what what a local commission service is to the core of what general practice are quite distinct. That we're looking at that bit, not the national contract, which is obviously delivered in a way nationally and negotiated nationally.
Thank you, Rachel.
Thank you.
I will come to the floor with some questions in a minute, but one of the questions that came to mind for myself was I absolutely welcome that standardisation approach in terms of those core community health provisions across our GP practices in Shropshire. But I wonder, does the ICB have a kind of response, I guess, in if a GP surgery or a GP in a surgery in an area has been identified as requiring some locally commissioned services, but that GP practice chooses not to take up that offer of that, whether it be resource and building space or staffing or other reasons, because it's very clear that those locally commissioned services are voluntary despite the financial input. So if it's been identified as an area to do with some of that serious mental illness assessment, but the GP practice is unable to deliver that, what's the next steps, I guess?
I suppose that's the bit around looking to see how we can make sure we get that provision for patients. It may look different depending on what that service is. So it might be local, other practices might be able to do that. There's the PCN model, there's federation models, there's different models that we can look at to make sure that those patients have that delivered. So I think the way that the architecture of general practice has moved, it does facilitate those conversations. I can't give you an absolute answer around that because it will look different depending on the service that's required. It may be sometimes we look to partners to support that as well. So if they're not able to be delivered by general practice, we would look out to partners to do that, so other providers. So there's not a single answer on that, but the absolute principles of this is that patients will get that service and be delivered in a way that we would expect to that standard. And again, you know, that we must always go back to those principles.
Thank you. And as a very quick follow-up, if, for example, there were a number of GPs within North Shropshire, as an example, where it had been highlighted as requiring of those locally commissioned services, is there potential, and apologies, I don't know the GP contract so well, but is there the potential for those locally commissioned services to almost be commissioned group-wide rather than singularly GP-wide? Because, you know, if they're covering Oswestry, Ellesmere and Whitchurch, for example, that's commutable and an ability to offer a service for a day a week, as an example. So
our first line would be to go with practices.
Yeah.
If that's going to give us a patchwork situation, then obviously we would open up those conversations to see how that could be delivered at scale. So again, some more detail will be absolutely as we work through this process. But the aim is for the practices to deliver it. If they are not able to, there's absolutely working at scale is the direction of travel. So general practice as a single provider, absolutely. As we go forward, we would absolutely consider that. And there's lots of examples where that that already happens, so it is possible to do that.
Thank you. I'll bring Dawn in.
Thank you, Chair. Firstly, thank you for your time today. Do appreciate you coming. Whenever I hear standardisation of services, it raises concerns in my mind. So, you know, same quality, same service. OK, that's great. But how are you going to ensure that services are not standardised to the average rather than the best current level of service, particularly in view of all of the financial pressures that all of these service providers are currently under? There's obviously a temptation just to find what a size fits all. I know that you're saying differently, but I want, you know, I'd need more reassurance on that. So how far along are you with the current mapping that's been carried out? Do you know which area is benchmark highest yet? Which area are you then using as the benchmark against which you are going to standardise other services? So it's great to hear your commitment to transparency. So will you provide us with the fully mapped current position as soon as it's available, please? Thank you.
So I'm going to I'll address your question around standardisation. So, you know, I'm a doctor, I'm a GP. You know, for me, it's about the best outcome for the patient and best practice. I'm responsible for that, and I won't be deviating from that. So when we talk about standardisation, we're talking about levelling up, not meeting in the middle. Okay, so there is, you know, there's national best practice. There are lots of areas of, and again, we're talking about a number of services here, so it's difficult to give you absolutely a single answer around this. But my position, you know, after many years of practice, the only way to do this is to level up to the highest level of best practice nationally. So standardisation means levelling up to best practice. It doesn't mean meeting somewhere between or levelling down. So that certainly is the core principle of why we would do this. So we would be looking at you know, best practice, best evidence, and you know, that's the way we need to absolutely function. And again, we'd have outcome measures that we would be looking at for each of those services to make sure that we can measure the outcomes and we can measure the standardisation. I feel a little bit guilty using the word standardisation now, because what I mean is it's that equity and highest quality that we would want to be meeting, and that will then give us, if that isn't being met, it would give us focus to how we can improve support, make sure that that standard is met. So I will always go back to my principles of being a doctor as well. You want the best outcome for the patient with the resources you've got in the available delivery that you've got as well. And you know, one of my passions is value-based healthcare. So it's, and we talk about value, I don't mean just value for money, because yes, that is part of it, but it's also value for the patient as well. So, you know, is that the best outcome for that individual patient as well? And sometimes, you know, that will vary depending on the patient. So there's something about value, careful stewardship of the resource we've got for the best outcome of the patient. So that principle will sit behind this as well. So in terms of the position where we are now, I would say, again, because there's many service lines, you know, whether we're looking at wound care, whether we're looking at phlebotomy, whether we're looking at those, we will have a baseline. We do have a baseline benchmark of some of those. That's not just the reason we're doing this, is I think we could do better, and we could do better in terms of managing them, monitoring them, looking at them. So as that data starts to come through, again, would be very happy and transparent to come back to you maybe 6 to 12 months to just talk to you about how that looks and how that differs and how the delivery looks different, and I'm certainly happy to do that. I'm not able to give you that stats in detail now, but yeah, again, happy to be transparent and open with you as to how those are working. There will be a process about how, so we're talking about from April 26, we're not, so there will be a process of implementation, and some of them will move at different rates. There's a core services that will continue with some of the services that are already being delivered, that we'll be able to, there won't be much change on when we think about some of the areas, but there will be some that have more significant change. So I think it would be good for us to just come back and maybe take you through some of those and how they've moved going forward, but happy to do that.
Thank you, Rachel. I appreciate that. I think that standardisation at the highest level is really important, and I think that's something to take away. Is there anybody else from the committee?
Yeah,
Terry.
I just ask, and I don't know if this is, well, I think it will be relevant, is the fact that obviously there's an awful lot of development going on in Shropshire. I don't know if it's the same in Staffordshire at the moment.
There is.
And one of my sort of concerns, for example, my elderly mother lives in a North Shropshire village with an excellent GP surgery that does actually offer phlebotomy, vaccinations, all of it, but they've currently got quite a lot of planning applications in. And I actually spoke to the GP surgery and they can accommodate one house. That's it. And they don't have the sort of physical ability to expand. I know in vaccination time, I mean, they're very efficient. I think they are incredibly efficient. But they've got quite an elderly population as well. So do a lot of things like wound dressing and things like that. And obviously constantly blood checking and things like that. And I'm just wondering how you're going to deliver the best possible services with increased numbers of patients. I know there's like Section 106 and you are being consulted, the ICB and NHS England. But I'm just wondering in real terms how that's going to translate into, say, additional GP practices where there's no capacity to physically expand. You talked about some of these premises actually cannot be expanded. I mean, in my own village, they've just recently cut a clinical room in half, so they want to deliver. They're excellent. The nurses and the GPs, they just can't cope with the capacity, and then they're going to have additional capacity. So I'm just wondering if that's being taken into consideration. Thank you.
Yeah, just to answer that, that might just be going slightly into the realms of the GMS contract, estates planning. There's you know, it's huge, yeah. So obviously, planning primary care services, and I'm talking about primary care, not just general practice services. We're talking about dental, optometry, the whole planning. There's you know, that we have to work with local councils, we have to work with communities around how that looks. I'm not going to deny it is challenging at times, and there are specifics around different populations and how it looks and neighbouring practices and all of that needs to be taken into consideration. It does impact on the local commission services, how we do it. I do think that's a whole separate conversation that we, you know, that we probably need to have around estate planning, primary care expansion. But I think we're slightly straying into a different conversation there. But I do take your point, and because at the end of the day, we've still got to deliver these local commission services. But that's a kind of add-on to the bigger conversation there, and it's probably gets a bit outside the scope of the conversation today around the local commission services. But I you know, thank you for your comments around it, because it's sort of running alongside it rather than the whole impact of it.
Thank you. Dawn.
Just a bit of a follow-up to
Yes,
the
sure,
one.
yeah.
So delighted to hear that you're talking about levelling up, and the fact that, you know, I fully support the fact you are on the inside fighting for this. You know, from your perspective, that is very important. The system can wear that down. So, you know, what I'm trying to get to is, you know, if we have more baseline data, you know, there should be ways that we can help and support you in making sure that you are fighting with some backup to level up and not succumb to the inevitable pressures of cost savings that we're all under. So that's what I'm trying to get to. Whatever you can give us, you know, we can then use to actually help and support you in what you're trying to achieve. So thank you.
Thank you. Just on that, I think you know, as you're probably aware, there's a lot of change and move in the ICB at the moment, you know, around clustering and some of the management change processes that we were going through. One of the positives about this is that actually moving towards a strategic commissioner, we are very much going to be data driven around population health management. So that will give us the very strong data as we work through these. So, you know, that capability around how we commission services and very much population focused will become that capability will just grow as we move in the next few years. But you know, that's a very kind offer, and thank you for that. You know, we talk about constrained finances. As I've said already, one of my passions is about value-based healthcare. It's about using the resources to the best ability that we can for the maximum outcomes for patients. And that lens, I will not steer away from that lens. It's not always easy, and I'm going to say there's challenges along the way, and each pathway will bring challenges with that. But if we can hold on to getting the best outcome for the patient, using the resources most effectively, trying to make sure those, when we think about the 10-year plan, hospital to community, I think we're set on a good path there, and we'll absolutely do our best to do that, and we'll keep you informed around this, and any support, we'd be most grateful as well. Thank you.
Thank you, Rachel. Rachel, you used the term local, and you used the term kind of thinking about local health. Yeah. How local is local in your respect?
That's a really difficult question. So I suppose we're talking about localities, we're talking about neighbourhoods, we're talking about that development. This is about bringing services that can be delivered as close to home as possible. And I suppose local to patients would mean general practice, wouldn't it? Their local surgery. It might mean, as we're commissioning, that actually it's on a PCN footprint, or there's a mix for me, or a sweet point in the middle where you get the locally delivered services at the highest possible quality, and that might vary, but we would absolutely aim to get that as close to home as possible. But there are some times when you need the best quality service and the best outcomes may be achieved slightly further away from home, but it's about any services that can be delivered by general practice, for them to be delivered in the community as much as possible.
I guess my concern is, and something that's been raised in previous committees, is around an ICB cluster that covers areas that are geographically and population-wise very, very different, and the rurality of Shropshire, as opposed to Stafford, for example, is quite different. And so that was my question around that local aspect, and what we're expecting our residents of Shropshire to be able to travel to get to certain services. And I'll give you an example that currently patients in Ellesmere sometimes have to travel to Whitchurch because they share a GP practice, but there is no public transport between those two towns. If you have a car, that's fine, or if you can afford to pay for a taxi, but there's no public transport. So while they may commission a service in Whitchurch because it's a much bigger provision than it is in Ellesmere, getting to Whitchurch is a challenge. So.
I think you make a really strong point there, and this is really important of why we're moving to neighbourhoods and making sure that even though we're looking at about 1.7 million patients, I think, across the cluster, that actually we still have the design and structure that means that we're able to pick that locality and neighbourhood picture up, so that we still focus on that, and we are designed in a way that does that, because that's really important. Because you're absolutely right, we've got some very different populations, and that's again is around population health management, and it's again back to the point around value. So if you're in a rural community, the value of having phlebotomy at your practice is huge, and that sort of individual value that brings, and then the subsequent benefits for the population around that are really important. So the population that we serve and the nuances around each population absolutely must always be considered around this. Thank you.
Good morning. I have a different question, especially about general medical service contract.
Yeah.
Because nationally, it's roughly £121 per head.
Yeah.
And in Shropshire and Elfenbrook ICB, estimate that cost roughly for £2,000 per head. And my question is, how much amount or percent will be transferred from secondary to primary and community care?
So I just need to be, I just need to be careful I don't go into the GMS discussion, because that's not really what we're here to talk about. I think if I just pick up the point around transfer of resources from secondary to primary, and again, I'm not going to be able to give you a figure about what that looks like, but as we work our way through pathways, when we talk about resource movement, it may not always be money. It might be staff that can work out in the community. It might be other, machines come out like ultrasound or whatever it is that come out into the community. So the shift is to make sure that that's done in a sensible way. Each pathway, it will look different. And so I'm not able to say there's a figure or percentage or what that's going to look like. It will vary across the geography, and it will vary across sort of nationally as well, how that looks like. But there will, in the 10-year plan around moving hospital to community, we take very seriously, and I think that's something that will evolve over the next. It's a 10-year plan. It will be an evolution. It won't be just happening on the 1st of April. So as that happens, it will become more obvious as that process takes place.
Thank you. Dawn.
Yeah, I just think because there is so much passion within our communities and within our members about actual GP services, I think you're not here today to discuss that, but I do think if the committee can arrange to have that kind of thing put onto the agenda, because clearly that's what everyone really wants to talk about, rather than the commission of the blood test and things, which is incredibly important. Important.
Yes.
But we really do need the opportunity to discuss those wider issues, I think, if possible, please, Chair.
I'll add that into my summary in a second. Absolutely, you beat us to it. If there's no further questions from the committee, Bernie, did you have any questions yourself?
No, thank you, Chair. I was just going to ask a similar question to Councillor Pfeiffer. Nationally, the huge majority of resources is in secondary care, and Councillor Pfeiffer articulated that in precise terms. So £121.79 is the current level for GMS, General Medical Services, compared with about £2,000 per head for secondary care. For the whole budget, £2,000 per person. And so, if we're going to meaningfully move resources from secondary to primary and community care, I agree that looking short term at the transfer of staff and resources is helpful, but for long term planning, I think there should be a move to more permanent transfer of these resources, and that they should be articulated publicly, and that there should be transparency about it, that there should be a lot of communication with local population, which is, I think, what we're trying to do.
Sure. So I agree with you. I mean, it's the move to with the 10-year plan. I think this is national conversations as well as local conversations, and as I said, I think it's going to take a number of years as we work our way through various pathways for that to become sort of business as usual as we do that. The way the contracts are moving in the neighbourhoods, that will facilitate and enable that. And I think it's about watching this evolution. It's not going to be something that just happens overnight. We're very used to the way the system's working at the moment, and it's about making sure within all of those pathways that resources are moved appropriately, at the right time, patients for the best care for those patients. So it's going to be an evolution, but I completely agree with your comments.
And sorry, just to come back for 1 second. Of course, the national neighbourhood health strategy is being rolled out in terms of principle, but there's very little funding behind it at the present time. And so clearly we need to ensure that that happens so that we can actually deliver on the aspirations of that strategy.
Absolutely, and it goes back again to using the resource that we've got in the most effective way for patients. And I think we'll always come back to that principle, and it's making sure that we put systems and processes in place to make sure that happens, regardless of whether you're primary, secondary, community. It's about coming around the patient to make those, using those resources most effectively.
This is no mean feat for you. that's the NHS, isn't it? So, okay, thank you. I think based upon what you talked about in terms of returning to the committee, I think that's a valid point, and based upon what Dawn talked about as well. So I'm going to make a recommendation that we invite you back to the committee 6 to 12 months time to provide an update on kind of the learning and the impact of the changes so far, and hope to get some of those kind of time scales for those impact assessments that you talked about, which would be really, really useful to see from a Shropshire resident's point of view. And in terms of ensuring that access to GP practices and neighbourhood health and estates and future planning are kind of considered. So, and we will look at those aspects, those topics within our future planning as well. I think we're already looking and thinking about that community pathway, aren't we? So, yeah, if I can ask you to return, that would be really useful. And thank you ever so much for your time this morning. I think. I think we are therefore yeah, I think you're good. David, I can't take questions from the public in this context. Yep, well I can. Yeah. Oh, okay.
It's in your gift.
Perfect.
And as a co-opted member.
Brilliant. Okay, so as a member of the public, no, but as a co-opted member of Joint Host, then yes. Apologies, David. I'm still learning. So feel free to ask a question. Thank you. Sorry. No, it's fine. Oh, are you okay? Sorry. Health and safety.
How much are you talking about?
In relation to
Cash.
So
how much are you investing at the moment in these extra services? What's it, LSC are they called?
Local commission services.
Yes.
Yeah. So we have a price per head that we invest at the moment. Again, that's the amount that is actually going to come to when we finally when we finalise that, but in the next few weeks. That will change. Again, I don't want to go into the figures right now, but we will be able to give you those. We can be more transparent about those as we go into April.
So, sorry, Chair, if I may ask a supplementary. I mean, I need to follow this because it's important. You talk about levelling up. The big question that a lot of the public will want to know is, well, how much extra investment are you going to put into levelling up? Now, clearly, you've not been able to answer that question. You don't even know what it is, what the budget is today, do you?
Well, I do, because we're still in negotiation around some of those services. I think it would be wrong of me to give those figures right now. So I'm happy to give those figures. In the next, as we go into April. Obviously we're still in some of those negotiations with the general practice. I think the principle is there will be more investment, it's not less. So the principle is there's more, not less. But the actual figures, I think it would be remiss of me to quote those now. That I haven't got them off the top of my head either, and I don't want to misquote in a public meeting around them.
Thank you, Rachel. I think at that point, any further information will be provided in kind of future updates, David. I think that's a fair comment to make at this stage.
Have you any idea? Sorry, Chair, but have you any idea what kind of percentage increase there will be?
Again, I'm really happy to give those when we've done that final negotiation.
David, I think again that's part of a future update.
Thank you, Chair.
Thank you, David. Thank you, Rachel. I appreciate that. Okay, I know you've got a GP surgery to get back to and you've got a heap of work to go to. Thank you ever so much for your time this morning and for answering our range of questions. We're all enthusiastic and passionate about our communities and health in Shropshire, so thank you for that.
Thank you, and I look forward to coming back, and we will make sure we keep you up to date as we go through that. Thank you.
Brilliant, thank you. I'm sure Rachel and Sophie will be in touch with some future comms as well, so thank you. I appreciate that. Give both Rachel's a chance to exit the room, and then we'll move on to Bernie's update.
Thank you, Chair. The Health and Wellbeing Board met last week, and it was quite a successful meeting. So the principal areas were Health Watch Shropshire. Lynn Corley, Chief Executive, gave a summary of recent activity and a forward plan for 26-27, but on the basis that Health Watch Shropshire is likely to be disbanded, sadly, along with all of the other Health Watch organisations, and as NHS. The NHS central organisation, which is Health Watch England, is also abolished. And board members strongly supported maintaining an independent voice and agreed to lobby MPs and government for clarity and resources. So the board agreed to send a letter to MPs and government seeking clarity and resources for maintaining an independent public voice in health. It was also agreed that the board would include the independent voice and Health Watch transition in the upcoming planning workshop agenda, which is on the 12th of February. So that's a really important area, I think, for all of us. And I think we're all very sad to see that Health Watch Shropshire is due to be disbanded. So then there was a presentation by the Assistant Director for Families First Partnership, outlining major statutory reforms, including multi-agency partnership, early intervention and community-based support for children and families. And clearly this chimes very well with the National Neighbourhood Health Agenda and Shropshire Council's moves in that direction. She emphasised reducing referral culture. So there are many young people being referred who could perhaps be managed in a different way using multidisciplinary teams, and leveraging community networks, including primary care and the other community resources, and the developing neighbourhood health hub services. Funding concerns and risks were highlighted with calls for a risk log, and that was agreed, and further board oversight. Board agreed to revisit progress in 6 months and to support council lobbying for better funding. There was a housing and health action plan update. So the head of housing, resettlement and independent living reported progress on temporary accommodation, regulatory compliance and partnership working, acknowledging a slower than hoped for pace. So it was suggested that plans to bring a future update on specialist housing needs and develop KPIs, key performance indices, for accommodation impact. And there were suggestions to better target vulnerable cohorts and integrate housing with health inequalities work that were discussed at length. And the action points were the development of these key performance indices for temporary accommodation, impact and specialist housing, and to consider further integration of housing with health inequalities and vulnerable cohorts in future planning workshops. There was an update on special educational needs and disabilities and alternative provision. So the Director of Children's Services, Head of Education Quality and Safeguarding, and the Senior Education Quality Advisor reported on SEND and alternative provision, highlighting ongoing national challenges such as funding shortages, long waits, and rural delivery difficulties. The local strategy has been updated through co-production with partners and parent carers, aiming for high quality inclusive practice and more local provision to reduce travel for children. The team is preparing for expected national reforms, focusing on a local inclusion support offer, including training, advice and direct support, with hands-on help for mainstream schools prioritised over just giving advice. The Government Schools White Paper, to be published later in 2026, will consider overall funding and special education needs and disability costs, which plan ultimately to be absorbed by the government budget following a spending review in 2027. Rurality and low funding were repeatedly raised as barriers, with Shropshire among the worst funded authorities for high needs. The board acknowledged the progress, commended the team's efforts and agreed to continue lobbying for fairer funding and to maintain oversight through the SEND and Alternative Provision Partnership Board. And board members of the Health and Wellbeing Board were invited to attend the SEND and Alternative Provision Partnership Board meetings for transparency and input, and I'm sure the same would apply to HOSC members. Health and Wellbeing Strategy. Rachel Robinson, the Executive Director for Public Health, presented a comprehensive update on progress against the Health and Wellbeing Strategy, combining outcome metrics and priority area delivery. The report showed improvements in some metrics, but declines in some areas such as healthy life expectancy and access, reflecting impacts from COVID and cost of living pressures. Key achievements include joined up working on children, young people, inequalities, prevention and community focus, but workforce and community safety reporting needed strengthening. The board agreed to review the report in detail at the upcoming dashboard workshop and to continue evolving the paper and bring back future updates to track progress. The Director of Strategy and Development at Shropshire Telford and Wrekin Integrated Care Board highlighted that the local Integrated Care Board achieved the most improved staff results in the country for planned care in the ICB update. The lung cancer screening programme has started with patient screening now underway. NHS reforms are impacting the Integrated Care Board, particularly through management changes and a voluntary redundancy scheme. The Directorate of Strategy and Partnership at SATH and the ICB Chief Executive Officer and Co-Chair of the Health and Wellbeing Board, NHS Shropshire Telford and Wrekin, emphasised the importance of recognising these improvements, especially in diagnostics and cancer care, while noting ongoing work is needed to ensure patients feel the benefits. The Shropshire Integrated Place Partnership provided a written update, but that was not considered at the Health and Wellbeing Board. And that concludes my summary.
Thank you, Bernie. I appreciate that. Dawn.
Chair. And thank you, Bernie, for your time today. I completely share your concerns about the loss of Health Watch and support the approach of writing to our MPs. But having tried this approach myself repeatedly in the time since I've been elected to absolutely no avail, I'm rather concerned about, I'm not hopeful about the success that it's going to bring. Now, do we have or can we develop a plan B to ensure that we still have an independent voice? Because it cannot be that commissioners and providers get to mark their own homework. Thank you.
Thank you, Councillor Houseman. Houseman, we're clearly in full agreement about this, about striving for an independent voice, and this topic will be discussed at the workshop that we're planning on the 12th of February. As well as writing to MPs, we'll be writing to central government. And indeed, I mentioned this particular topic to Professor Sir Chris Whitty when he came and visited us recently. And so and I followed that up with a letter to him that included this aspect. So he and I think the government are fully aware of the strength of concern and feeling with regard to having an independent patient voice in Shropshire's healthcare.
Thank you. Quick follow-up, because I'm on the MPFT Governors Board, which is largely with volunteers, external experts, and if they're trying to save money, is there no way that that kind of approach could be set up and used in, with regard to an independent voice?
Thank you, Councillor Husband. I presume you're referring to the Midlands Partnership Foundation Trust, which provides mental health care for the people of Shropshire, and clearly that they will be a partner in these discussions. When Dr. Gallio talked of transferring resources from secondary into primary community care, she will have been referring to lots of different areas of activity, and that may include mental health provision. The mental health provision has recently had some changes with a new CAMS contract and other changes, which again we'll be discussing at the forthcoming workshop. But yes, we need to bring as many partners and resources in to strengthen our independent voice as we can.
Unless there's any further comments from Bernie. Okay, thank you, Bernie. I appreciate your time and your thoroughness. Thank you. We are then going to move on very briefly to 7 and then 8. So work is ongoing to find a new member for the Joint HOSC Committee. It's to do Joint HOSC, and HOSC is a commitment in itself. So we will carry on looking and roll that onto the next agenda item, into April. But we then will move on to my update from Joint HOSC. And I think my update absolutely reflects what we've just been talking about in terms of that independent patient voice. And over the last couple of months, the Joint Health Overview Scrutiny Committee has kind of been focusing on strengthening how patient experience and community voices shape our work. And it's included a lot of informal meetings and planning sessions with officers, Health Watch and NHS partners to ensure our scrutiny is focused and grounded in actual real experiences of our Shropshire residents, which are really important. The committee has agreed to look more closely at patient pathways and community health provision that supports Shropshire residents. We've looked today at that locally commissioned services as a starter. And we'll be reviewing that community health provision as part of a wider system change in progress. Our aim is to understand how people move through those services and where those pressures or gaps are being felt locally, and locally being that word. And we talked about councillors having an important role in helping to bring forward patient experiences and local concerns from their communities to inform our scrutiny. So unless Dawn has got anything else that she wants to add to that. Fine. So our next meeting actually takes place on Friday the 13th of February, and we start some of that work then. So I look forward to that. And I obviously decided to bring in Bernie before my own updates. There we go. So if we move therefore on to item 10, which is the work programme.
Thank you, Chair. Sophie Foster, Overview and Scrutiny Officer. So I will take the work programme as having been read, but I'd just like to pose some questions really to the committee to reflect on, to support your discussions of the work programming going forward. I'd ask you to consider, are there any topics which are missing from the programme, which either from further work outside the committee or what you've learned from today, which you feel should be considered? Also, if there's any awareness of topics which are coming to Cabinet that Scrutiny should be aware of in terms of pre-scrutiny. Which areas you feel would add most value by considering the context of especially the improvement plan, and being able to focus on what should be prioritised, because really conscious that there's a lot of change happening within both the health systems and within the council and transformation ourselves. So there are some really important topics to be reviewed, and it's about how we can support you to prioritise which of those where you feel the committee can add the most value through your work. And whether you require, therefore, any further briefings or investigative work to be able to inform your decision to prioritise particular topics. And then to also be able to begin to decide, as we look to the next meeting already in April, on the 20th of April, if there's anything that you'd need to know more about, or that you already are clear on of which items you'd want to take forward to that meeting in April. It may not be possible to decide all of this today because of perhaps needing further information, but these would be the things that I'd recommend for you to consider when reviewing your work programme. Thank you, Chair.
Thank you, Sophie. I think from today it feels like one of the things that we should look at is how that ICB identified need for a local community, in inverted commas, actually translates to an offering of services for our local residents. I think that, given that those LCSs are voluntary, and they look at different ways of offering that service, but what does it actually translate into? That feels like an area.
Yeah, and I think what came out of today is members are very keen to actually know about the GP contract, actual services on the ground. So I don't know, that may well be included in the local implications of NHS reforms, but if it isn't, that is something I think that we do need to understand more about. I know we've got oh, forgive me, I forget her name, coming to talk to us about the utilisation of our local hospital facilities. Joe, that's it, Joe. Yeah, sorry about that. So those two areas are really important. We haven't got a full handle on it at the moment of just how these changes are going to impact at what we see as a local level, which is slightly different from the sort of large areas of the ICB
versus local versus ward.
We really do need to have a very good handle on that. So however that's built in, whether that's with an existing item on the agenda or an additional one. But thank you.
Yes.
Yeah, I'm always hesitant about raising
local. Speak up.
Sorry. I'm always hesitant about raising local issues, local experiences, and this may well fall outside the remit of the committee, which considers quite broad issues. The ICB, communication with the ICB is obviously important to this committee. The ICB has taken over responsibility for managing the budget of the West Midlands Ambulance Service. The WMAS has a ambulance station, which actually falls in Councillor Bentinck's ward, but just on the edge of mine, which it has proposed to move. It proposed to build a new one for Shropshire because it's an old bakery basically, and they've been there for 13 years now. I wonder whether we could bring either the ICB or the WMAS before us to consider or to ask them how progress is going with that. The lease on that ambulance station runs out in August next year. I've tried to get assurances from them or communications from them within the last few months without any results as to how progress is going. Would that be something that the committee could consider?
I think we'd already thought about a review of Health Hero and West Midlands Ambulance Service. So I think that local context could absolutely be brought into that aspect.
I think the discussions were that would be potentially a joint HOSC discussion, because at joint HOSC, because it's the opportunity to meet with both Telford and Shropshire local authorities underneath what was the integrated care board footprint, and now beginning to look to that wider integrated care, if I can say, integrated care board footprint as well. So I think absolutely, as the chair says, that there is a plan to review that, but it may be that it's looked at the joint health overview and scrutiny committee as opposed to this one initially. But I think,
however, the outcome of that might facilitate a HOSC discussion about that provision more locally.
Okay.
Okay.
Thank you. I vaguely remember mentioning dentistry in the last meeting and can't see that on the work schedule. So I was just wondering, is it sort of integrated in something else, or would it be a separate item?
Dentistry again, something that's HOSC related or joint HOSC related?
I think it depends on the angle that the committee would wish to take. So I think there's been discussions previously where it can fold into the sort of primary care and services access more widely, or it could also, because again it is a service that is commissioned at a system level, could be looked at a joint HOSC level as well. So it would really be where the committee again feels you'd be able to add the most value to that topic.
Any thoughts about if it's a local concern? I know there's a national concern.
Yeah, I think it's the fact there are so few NHS dentists available. I know Oswestry is particularly bad, but I assume it's a similar thing across the county. There just doesn't seem to be NHS availability for any dentists at all. So I would take it on whether you think it is a joint HOSC or, but it was just because it was mentioned in the previous one, and I just noticed it was.
Whether we take it as a part of community medicine provision in terms of rurality and access in Shropshire. That seems like a fair discussion to be part of that. Yeah. Is there anything else that the committee, Adam?
Can I have two requests if you don't mind? Okay, one will be to have a little bit more discussion about GP out of hour, because we know that the contract has changed. It's already over a year ago.
No, so Health Hero changed in October, and so we are looking to review it in April.
That's great. And the second one, well, because we know that it's also a private ambulance transport company, and recently I had a query from one of the patients from Shropshire. Personally, my friend, she's a dialysis patient. She was waiting 6 hours for the transport from hospital to home, and I'm just only wonder how it's looked at KPIs regarding especially dialysis patient, because as far as I know, they're not on the priority transport list, and how many of the patients waiting longer than 4 hours for the transport.
So are you talking about the private patient transport that's
yeah.
offered for people going home or going to regular appointments like dialysis,
yeah,
rather than the West Midlands ambulance service provision?
Yeah.
But it's patient first. There's a
no. It was Isaac. Now it's a different name.
Okay.
I don't remember.
So it's more of a look at the local provision that patient transport is used and paid for locally in Shropshire, leaving hospital or coming into Shropshire for regular appointments. Yeah.
I'd probably suggest that if it felt appropriate to committee, that it's a bit of more investigative work to understand that further. So perhaps a briefing to be able to understand what the current provision is, who those providers are, and sort of how that works, to be able to understand if there are any sort of areas that would then add value by the committee reviewing. If that felt appropriate.
Yeah, we can understand a bit more before we start to scrutinise. A bit more of an overview. Thank you. Hello.
Thank you, Chair. If we're going to have a briefing, can you ask whoever's going to be doing the briefing to give us facts, figures, data, rather than
Anecdotal evidence.
yes, and a nice sort of overview. We need data, please. Thank you.
I think it would be useful to get a perspective from what the NHS has, whether it's a KPI, whether it's an expectation, whether it's an SLA or something. But I know with a lot of private medical transport, there's a large majority of it that's booked by the patient themselves, rather than, I say, unless they are receiving long-term things like dialysis as an example. So I think there are many components to it, but it's definitely worth some investigating. Thank you. Is there anything else from the committee? No? Okay, fabulous. So we've done item 10. We're actually back in order again. We are on therefore to item number 11, in Dawn's one. After a tricky morning, you're here and you're able to provide an update, so thank you.
Thank you, Chair. I'm pleased to provide an update on the work of the Health in All Policies, HIAP, and Planning Task and Finish Group. The group was established to accelerate the embedding of health considerations within planning policy, drawing on the needs of adult social care, children's services, public health and wider partners. So what the group is aiming to achieve, our terms of reference set out a clear purpose. Firstly, to review how current and emerging planning policies can better support health and well-being, including for residents supported by adult social care and children's social care. Then to produce a set of practical evidence-based recommendations that ensure housing, design, location, accessibility standards and wider planning decisions contribute positively to long-term health outcomes. And to support in embedding health in all policies, linking planning with social care, public health, early intervention and community well-being. The group is working to deliver its final set of recommendations by the end of February 26, aligning this with officer work streams already underway. How we've been doing the work? Well, the group has undertaken a rapid evidence multidisciplinary approach. Desktop research of local plan content, design guidelines, strategic housing market assessment data, housing learning improvement network needs assessment, and health in all tools. There's been a lot of reading. Engagement with officers across planning, public health, housing, adult and children's social care and portfolio holders, including detailed witness-style sessions throughout December and January, with more planned for February to help close any gaps in what we have learned. Then benchmarking and case studies, including Marmot principles, rural poverty metrics, community land trust models, design review frameworks and accessible housing policies. Plus gap analysis and iterative questioning undertaken with officers, including follow-up actions on data gaps, viability information, developer engagement and user voice research. And then finally, engagement planning with service users, carers and providers. This has allowed rapid triangulation between policy intent, operational data, community needs and practical deliverability. What we've discovered so far, well, the key themes that are emerging. Across all sessions, a number of themes have emerged. Firstly, accessible, adaptable and specialist housing is a critical need. There is identified unmet need for adaptable homes across the county. Evidence supports mandating proportions of M4-2 and M4-3 principles homes into future policy balanced with viability. Early engagement with developers and clear policy expectations are essential. Excuse me. Rurality and hidden deprivation drive health inequalities. So rural poverty, digital exclusion, social isolation and poor transport access are central barriers to health. Planning can support mitigation through energy efficiency standards, broadband community hubs and local needs development. C. Social care needs to be strongly embedded in planning. The needs and harms assessments shows that housing and planning decisions can either reinforce or relieve pressures on families. Early intervention opportunities could be enhanced with stronger alignment between social care services and planning. D. Health impact assessments. A Shropshire-specific health impact assessment tool and toolkit already exist and could be implemented via supplementary planning document while awaiting the new local plan. This can be incorporated into the high quality design SPD for simplicity, avoiding the need to develop a standalone health and wellbeing planning document. We don't need to add additional requirements or more than are absolutely necessary to people. Clear thresholds for applying HIAs still require agreement. Currently out for consultation, the proposed changes regarding the National Planning Policy Framework, amended at the end of last year, still need to be fully understood. In particular, changes around validation requirements such as checklists or impact assessments and the ability for local authorities to implement them post-June 26 is not yet clear. Work on the implementation of this tool has been paused until the changes to national policy are more apparent. Health in the interim will be given greater consideration than previously due to the high quality design, which will be reviewed and amended through a health in all process, as well as a commitment to involvement of the development of the local plan. The group therefore recognises that its final recommendations must take these constraints into account, particularly the need to focus on strengthening health considerations within the revised high quality design where possible and ensuring alignment with emerging national policy, which now embeds health more explicitly within planning policy and decision-making processes there before. Strong appetite for integrated approaches across council services. So officers described significant opportunities for improved early intervention, asset mapping, multidisciplinary teams and localised community hubs. This has been a key focus and will continue to be. Gaps still being addressed. Well, the group has been systematically closing the gaps in Health Watch evidence, end user lived experience input, providers experience input and meeting with commercial developers. These items are still in progress. We will be conducting them before the final report is delivered. So what we're asking of the committee today, officers are currently doing much of the technical work required to shape the new local plan, the health SPD and the HIA framework, right now in parallel with the group's work. To ensure our recommendations directly inform and support this work in real time, we are asking that the HOS committee agree that the Task and Finish Group's final report does not need to return to committee for formal sign-off prior to its submission to Cabinet. Instead, we propose that a draft final report is circulated to all HOSC members for overview, comment and input, that the chair of HOSC and the chair of the Task and Finish Group then finalise the report incorporating members' comments, and the final version is submitted directly to Cabinet to align with the active policy development timetable. This approach will avoid unnecessary delay, ensure the group's findings influence the emerging local plan and SPDs at the right moment, and maintain transparency and member oversight without creating procedural bottlenecks. The group has made, the group has made rapid progress thanks to strong officer engagement and support. Thank you, Sophie. And the group's hard work and commitment, and I'd like to thank them all for this. So I welcome any questions.
Thank you, Dawn. Any questions from the committee? Dawn, thank you so much. I think when you started this, it's got bigger and bigger since you started it. And I think it just absolutely highlights that health in all is in all parts of what we do as a council, and planning is one of those parts. And it's really good to have a direct, positive, immediate impact upon how we deliver planning at Shropshire Council level. And some of the outcomes are predictable and some of the outcomes are interesting, and you know, you're absolutely right. We've got that impact assessment already there, but it's solidifying that in many respects. And there's lots of changes afoot that around planning, and there's obviously a health kind of priority in there as well. So that's really positive, isn't it? But you've had so much input from like Harkins and various other providers that it's been a really positive and relationship building experience from the outside that I can see. And so thank you for that. I really appreciate that. Dawn.
Just as an aside, we have identified a lot of officer support, willingness, and knowledge of what these issues and where the blocks are, and actually a degree of belief that we're already doing some of these things. However, reality is showing that's not always the case. That there certain things are being said about how supportive of planning development to support health in all policies is, but then when you actually look at refusals for planning application and you look at refusals at what's the appeals when they've gone to appeal, there's not, it doesn't always correlate. So that is something that we will be looking into and make sure that we feed back on in the final report. Thank you.
It's really important that we keep banging the drum. So yeah, and hopefully other local authorities are doing very similar works. So thank you for that. Yes. Yeah, so one of the requests from Dawn further to that task and finish group was that if the committee are minded to accept that we don't wait until the next committee, that Dawn and I work together further to any questions from any members, and we work together to finalise that for Cabinet, and then potentially you can get that to Cabinet March, yes, so as soon as possible in March. So unless there are any queries, concerns, issues with that, I'll take that as recommended, and that will be our positive step forward. So yeah, we'll work together for that one. So thank you. Brilliant. I think, unless there's anything else that I have failed to mention or gone in the wrong order of this morning. Okay, brilliant. So the date of the next meeting is Monday the 20th of April. Pop that in your diaries for all those concerned. And thank you very much for your input this morning. It's really good to have open discussions, despite our minimised numbers, on some really important issues, and starting to build those relationships again with the ICB in all of its guises. So thank you very much, everybody. And I'll bring the meeting to an end.